Hello, and welcome to today's event, Innovating for a Cure, Breast Cancer Breakthroughs. We are delighted to host this event in observance of Breast Cancer Awareness Month to discuss innovation in breast cancer detection, access to quality care, and to hear about how health equity plays into breast cancer care. I am Stephen Collins. I'm the CEO of Matter. We're a healthcare technology incubator and innovation hub with a mission to accelerate the pace of change of healthcare. We do three things in service of our mission. First, we incubate startups. Since we launched in 2015, we've worked with more than 800 companies that range from very early to growth stage startups, and we have a suite of services to help them at every stage of development. The second thing is we work with large organizations like health systems and life sciences companies and payers, and we help them strengthen their innovation capacity. We help them find value in emerging technology solutions, empower internal innovators to unlock the value of their ideas, and create a more human-centered healthcare experience through system-level collaborations. And third, we are a nexus for people who are passionate about healthcare innovation. We bring people together to be inspired and learn and connect with each other. And we produce a lot of programs, including large-scale events for the broader community like this one, as well as small forums that are exclusively for our members. According to the CDC, there are about 240,000 new cases of breast cancer in the United States each year, and about 4 million breast cancer survivors living in the country. Innovations in early detection and diagnosis and treatment have helped to improve survival rates. They've helped the quality of life for survivors, although we still have a long way to go to provide equitable diagnosis and care and support. And today we're joined by a panel of experts to not only bring awareness to breast cancer innovations, but also hear about their stories and the communities that they have reached. Our moderator today is Dr. Melvin Gaskins, who's the Senior Medical Director for the Oncology Benefits Management Program at eviCore Healthcare. Dr. Gaskins is board certified in medical oncology and is a member of the American Society of Clinical Oncology. He's been in practice for more than 20 years and brings a deep passion for serving patients throughout their journey. We were planning to have three panelists in addition to Dr. Gaskins, but unfortunately, one of them, Ricki Fairley, who's the CEO and co-founder at Touch, the Black Breast Cancer Alliance, is no longer able to join us. So we will have Dr. Gaskins and two terrific panelists to dig into the conversation. If you have questions for either Dr. Gaskins or the panelists, please put them into the chat, and he'll do his best to weave them into the conversation as appropriate. And on that note, I will pass it over to Dr. Gaskins, who will kick things off, introduce our panelists, and dive into the discussion.
Good morning. Thank you for the invite. And I just wanted to say initially that this is a very important program. Before the panelists introduce themselves, I just want to give you an idea of the scope of breast cancer and how important this is. In 2023, they're estimated to be close to 298,000 women diagnosed with breast cancer and 2,800 men. That represents about 30% of women, that represents 30% of cancers diagnosed in women. And women have a lifetime risk of about 1 in 8. And this results in about 43,000 deaths due to breast cancer. It's the leading cause of death in Black and Hispanic women with respect to cancers. It's the second leading cause of cancer deaths in white Americans, Indigenous Americans, and Native Alaskans. We do see disparities, as Black women are 40% more likely to die of breast cancer. And part of that may be that 1 in 5 have been diagnosed with triple-negative breast cancer. And so we're going to get into some of the innovations and look at these disparities with a couple of well-renowned experts, and I'm going to have them introduce themselves. If I can have the first panelist, Mr. Christopher Kunney, please introduce yourself and please give us a little story about your background being involved in breast cancer.
Sure. Well, hello, everyone. It's a pleasure and an honor to be a part of this discussion today. So thank you to the leadership at Matter for inviting me to be a part of this important conversation. My name is Christopher Kunney. I currently serve as the managing partner for a company called IOTECH Consulting. We are a healthcare technology, management consulting, and innovation firm. My background is in the technology side of healthcare, having spent over 20 plus years as a healthcare technology leader, former CIO, advisor to tech startups, academic institutions, government agencies, and healthcare organizations. I also currently serve as one of the American Cancer Society's Men Wear Pink ambassadors. And the role that we play as ambassadors is to bring, again, greater awareness around what the American Cancer Society is doing to support cancer research, specifically breast cancer for women and breast cancer for men, as a matter of fact. We'll talk a little bit about that, I'm sure, as a part of our program as well, too. And so I'm very excited to be a part of this. And I just wanted to share, too, that in 2020, female breast cancer actually surpassed lung cancer as the most commonly diagnosed cancer worldwide. And to your point, I think Dr. Gaskin mentioned the number of individuals who are dealing with it on a day-to-day basis. On a positive note, though, we have seen results through early detections that have increased greater awareness through mammography screenings and advancements in treatments, such that we're seeing a survival rate of almost 3.8 for almost 4 million cancer survivors here in the U.S. as well, too. So I'm very excited about, although it's still a prevailing illness, but I'm very excited about the progress that we're making to support women and men who are dealing with this deadly disease. So it's a pleasure to be here today.
Okay, thank you, Mr. Kunney. Our other panelist is Dr. Olivia Phillips. She's a breast surgeon. And Dr. Phillips, I'd like you to introduce yourself. Tell us something about your story with breast cancer, and also tell us briefly how patients come to see you.
Hi, everyone. I'm Dr. Ryland Gore, and I'm a.
Sorry.
It's all good.
I said your name wrong, Dr. Ryland Gore. Sorry.
It is all good. So I am board certified in general surgery, and I'm a fellowship trained breast surgical oncologist. So I specialize in the diagnosis and surgical treatment of benign and malignant breast disease. And so this is something very near and dear to my heart, mainly because I didn't fall into it, because I've always been involved in women's health. And even before going to medical school, I did the whole public health route. And my specialty was maternal and child health. And so I actually thought that was going to be OB-GYN, Dr. Gaskins. I hated it. I was like, I cannot do this. But to still be able to do surgery, which I absolutely love, and be able to impact women's health, especially as we see this problem continue to grow and grow and grow and grow. And then getting into surgical treatment, one of my passions during general surgery residency in Chicago was disparities, and how do we address surgical disparities? It's not just with breast cancer, but across the board. And so that's something I feel passionately about, and I'm excited about us having this discussion today about how we can begin to bridge that gap, whether it's with technology, whether it's with improved diagnoses across the board, so that we can begin to eliminate this disease, even though we do see better treatment modalities and better diagnoses modalities. And from a personal standpoint, I think all of us in this room and on this panel know somebody, or we've been personally affected by it, by breast cancer. And it hit my own family. My mother's twin actually was diagnosed with breast cancer. She's an educated woman. She was a registered nurse, and she fought this in silence. And even though she had the resources, she had the support system, felt like that this wasn't something that she could talk about. And she ended up dying from metastatic breast cancer and didn't even know who I was in her last days as I, helped to take care of her. And so I think we need to continue to, even though breast cancer is a championed cause, continue to talk about the stigma around it, talk about the stigma around these diagnoses, and seeking help when we need it, and having those conversations with our friends and our families and our networks. So thank you to the leadership at Matter for having me, and I'm excited about being on this panel with these amazing individuals.
Okay, thank you. One of the things that I always like to mention is that breast cancer is very curable. A lot of times people think every cancer is incurable, but cancer is very curable. And I think it was mentioned earlier that there are about 4 million survivors of breast cancer in the US. So more than likely, if you're passing somebody on the street, you may be passing a survivor of breast cancer. You just don't know it. But in that line of thought, I'll say that breast cancer is not only about the medical treatment, it's about the patient education and advocacy. Let's discuss the role of patient education, awareness, and advocacy in improving the outcomes and access to care. You want to start with that, Mr. Kunney?
Sure. No, absolutely. And one of the things I was remiss in sharing is kind of my own personal story as well, too. Unfortunately, my mom lost her battle with cancer. It wasn't breast cancer, but it was cancer. And so I understand the effects of that in my family. And then on a positive note, my mother-in-law is a 30-year breast cancer survivor as well, too. And so I've seen it on both sides in terms of the effect of cancer if it's not caught early enough and treated. And then on the other side, if there is, if it's caught early and then dealt with aggressively as well, too, you can have a long and productive life as well. And to your point, there are a number of different factors that really affect, especially underserved communities around, health equity, especially when it comes to things like breast cancer. And I really put them in 3 major categories. We hear this term called social determinants of health, which I think is pretty common. But there's 2 other areas, too, that we need to explore also along with that, and that's the political determinants of health and what I also call the digital determinant of health, the digital determinants of health. When you think about the social determinants of health, those are those factors that are non-clinical that really impact someone's overall health outcomes in terms of where the individual is born, where they grow up, how they're educated, the type of foods that they have access to, the type of care they have access to that has a direct correlation and impact on someone's health. But also when you think about the political components of this, what about the laws and regulations and rules that might play a factor and have a factor in getting access to care, especially for those people who are underserved? So there are policymakers that we are putting into office that are making decisions about individuals in underserved communities' ability to get screenings, to be able to afford quality care, to be able to have access to medications that might help them in their treatment of breast cancer and other illnesses as well. And then, talking about it from a technology standpoint, or those digital determinants of health, these individuals having access to technology so that they can get greater awareness, education, knowledge, information, a support system around them, access to care through things like virtual care and telemedicine technologies. And then also being able to have devices that can monitor both proactively and passively their current conditions as well too. Having access to those things will have or the lack thereof in many cases, can have a direct correlation and impact on someone's ability to get better educated, have access to care, understanding what options are available to me, and a support system around them that will improve their outcomes down the road as well too. So I think we have to look at this thing as a multifaceted perspective that we have to take a look at in terms of how we treat cancer and other illnesses within communities that have been underserved.
Dr. Gore, I want you to comment on that same thing, but from the perspective of someone who's been diagnosed and that you are seeing in terms of how well their education and access will help them follow the pathway towards cure that you would give them.
You know, it's interesting because I think that we've all seen so much disparity research came out, especially 2020 to 2022 during COVID. And what's very interesting about this, unfortunately, is that when it comes to African Americans specifically, it doesn't matter. We've seen this with maternal and child health also, maternal morbidity. Your education level doesn't matter. Your insurance status doesn't matter, even though we do know that those that are uninsured or underinsured fare worse. It doesn't matter. You can go to the best hospitals and you can still be at a real disadvantage because of your race and your race alone. So having a discussion about that. But when it comes to breast cancer specifically, we do know that African American and Hispanic women are at a disadvantage from screening all the way to survivorship, controlling for all of these other factors. And why is that? And so we really have to look, like Chris said, at systems-based situations. And on the public health side, the social determinants of health, a really big thing also is environmental justice. As far as systems go, we know that Black and Hispanic women are more likely to go to radiology centers, for example, that are not accredited. And so that impacts who screens you and how well you get screened. Are there up-to-date machines in there, mammography machines that will actually show what it needs to show? Are there actually radiologists who's going to read the mammogram? It's wild to me that this is something that minority women have to be concerned about. But I personally received a radiology report from an independent center, and the person that read that mammogram was a chiropractor. In 2023, wow. Who has no medical school training, no radiology residency, no breast training. And so these are the things that we have to think about when it comes to diagnoses, delays in diagnoses. How long does it take a Black or Hispanic woman to actually get the report that it was a problem, that it was abnormal? Average is greater than 30 days for women who are minorities to get a report back saying that it's abnormal, and greater than 60 days to actually get a biopsy. And I've seen this happen in real time, especially here in Memphis, to get a biopsy to show whether it's cancer or not. And so all of these things are cumulative and leads to the problems where we see delays in diagnoses, we see later stage at diagnosis, and we see more aggressive disease, things that we can control on the system side. But we're not doing that. And so beginning to have those conversations. And Chris, I really love that you brought up the political impact on breast cancer, because one thing that was really popular, very popular this summer, I want to say around May or June, the United States Preventive Services Task Force has now said that women should get screened at 40 and they get it done every other year. Well, that's interesting. Dr. Gaskins told us some of the data, right? Like, 40% more likely to die if you're Black from breast cancer. What we're also not talking about is that we are more likely to be diagnosed before the age of 40. So it was already always saying, let's start mammograms at 50 to 74, and let's do it every other year, when we know that mammograms pick up on so many things up to 2 years before it becomes palpable. But also this suggestion that we should get it done every other year, starting at 40, when we're getting diagnosed before the age of 40. My youngest patient was diagnosed at 19, and she's Black. So these political things, who we have on these boards, there aren't any surgical oncologists or medical oncologists on the preventive services task force. And so it's hard, it's a hard pill to digest, but we really have to look at all of these things with a very discerning eye when we're making policy, when we're talking about changing systems, and when we're talking about how do we treat people so that we can level the playing field and that there's actual equity in health equity.
No, absolutely. And I just wanted to also follow up on that is how do we get more women of color involved in clinical trials as well, too, so that the research, to your point, starts to arc towards the reality of how they're dealing with these diseases that are occurring much earlier, in their life than maybe their white counterparts as well, too. And so how do we get, physicians like you to reach out to their patients, to encourage them to be a part of clinical trials and research, such that, again, we can start tilting the arc to a more equitable way of viewing and treating patients that don't look like the majority of some communities as well. And then how does the technologies that we're using also that may have inherent biases built into them as well too? When you look at things like AI and machine learning, for example, a lot of times those technologies will misdiagnose patients of color. Because the information that's being used is based on a different demographic as well too. And so in some cases, those AI-driven analysis may not always may create disparities as well, just because they're not designed in a way to look at different other ethnic groups' physiology the same way, differently than they would look at their white counterpart as well.
Mm-hmm.
One of the things I'll just add in terms of disparities, sometimes there are very little things that people overlook that can cause big disparities. And I always give an example. I worked in a program under, I'll just say, a big time hospital. I don't want to mention their name, but it was a program designed to provide oncology services to underinsured patients. And what I found in this program was that even though most of the costs were covered, patients would miss appointments based on they didn't have the copay. And the copay would be like $20. Right. So I went back to the group and I said, look, can I see these patients even if they don't have their copay? And I was told, this was the exact words. They said, well, if they have Medicaid or something, they must be working, so $20 shouldn't be a problem. And I realized that the scope of the problem was completely lost on them.
The disconnect, yeah.
Absolutely.
There are people that, check to check, everything is covered. You don't have extra for a copay.
Exactly.
So something little like that, it becomes a big problem. In terms of disparities.
That's right. So, when you have to choose between keeping your lights on or, feeding your kids, versus going to the doctor and taking that $20 for copay, the choice becomes pretty simple for a parent or a loved one that I'm gonna sacrifice my own health in some cases because I have children and other responsibilities as well. And then the last thing I wanted to comment on, which I'm sure we'll touch on a little bit as well too, is the lack of professionals like Dr. Gore and Dr. Gaskins, yourself, in rural communities as well, too. The fact that we don't have oncologists and specialists in those communities that can help diagnose patients earlier in their treatment so that they can avoid, more the greater progression of the disease. I know it's my mom, for example, who didn't have breast cancer, but she did have cancer. She was going to her primary care physician for years, and she had blood in her urine, and he was telling her it was normal. That was normal, exactly. And it wasn't until it got so pervasive that further tests were done, and she had, unfortunately, kidney cancer and had metastasized. And so we have to be advocates. We have to hold our healthcare leaders accountable, but also we have to find better ways of getting them access to care, understanding what these social determinants of health are in these communities as well.
Mm-hmm. Mm-hmm. I find that so many of the most cities, most of the big name, big brand hospitals that exist, they have outposts in other places. But again, to your point, both of y'all's point earlier, meeting patients where they are. Everybody, even if you have a clinic in their small town, may not have a ride to get there, right?
Right.
And so, you know, you got to go down to where the patient is. We don't talk about that. We don't talk about that at all, or have a bus. You know, so many, we have resources like that in big cities where there's a bus that'll pick you up, or the church bus that'll take you if you make an appointment or whatever. But just finding ways to get creative. And I find that even with the resources, a lot of these places don't have the creativity, and they don't know how to talk to or connect with these patients. Because even if you have the van, even if you have the everything, if they don't trust you, and that's one thing that I know, and that I've tried to explain to, you know, some of my counterparts, if they don't trust you, then they don't care about your bus. And so building, you know, bridging that gap, because you talked about clinical trials, and getting more of our people involved. I think we make up less than 3% or something of participants in these
Right.
clinical trials overall. And there is still a lot of fear around experimentation, the history in this country, and we don't like to talk about it. We like to think that we're so progressive and that we're beyond it, but the old school generation, they're still thinking about this. They're still
Absolutely.
thinking about Tuskegee. They're still thinking about Henrietta Lacks. They're still thinking about all of these other North Carolina, you know, sterilizations that happened in the 60s and 70s, because there is a generation that still remembers that. It's not that far removed. And so I think further education, having more physicians and physicians of color. And so that means we have to train more physicians of color so that patients get physicians that look like them and who can offer culturally competent care, so that these discussions can be had.
Absolutely. And I do think we also need to.
Unfortunately.
No, I'm sorry, I didn't mean to interrupt you, but I was also going to comment, also investing in community health workers as well, too. You know, having people that are local, that are within those communities that they do trust and do have a relationship with, that can be the tip of the spear as well, too, that encourages them to go get tested or to identify if there are symptoms that might be leading towards a more aggressive disease that might be happening, you know, making an investment in those resources as well, especially in communities that don't have access to, specialists like yourself and others within those communities. They can be that tip of the spear and encourage those people to go seek additional treatment and then be an advocate for those individuals as they're going into these settings where they don't trust the healthcare workers as well.
Grassroots. Yeah. I mean, we saw it work with voting, right? So absolutely.
Yeah, exactly. Absolutely.
Yeah, and I think I for a long time worked academically at the Howard University Cancer Center, and one of the things that we noted trying to get Blacks on clinical trials, no one ever mentioned to me about Tuskegee. And so I think what you're talking about is a matter of trust is a real thing. So that's part of the problem. So we see the problem. So what can we do to sort of address these disparities and ensure competent care for everyone?
Yeah, a very good question. You know, what's the silver bullet, right? I think it's a much more of a holistic approach. It's definitely, I take those three areas again: social, political, and then technological, or as kind of the lenses I look at it from a social standpoint. We have to invest in individuals in our communities, again, like the community workers, healthcare workers, who can be the tip of the spear and help educate, advocate, and encourage individuals to go seek proactive screenings so that they can get in front of these issues before they become more pervasive, I think is key. I think, to your point, working with our HBCUs like Howard and Morehouse, which I'm involved with, and others, to start creating a pipeline of professionals as well that look like the communities, these underserved communities as well too, so that they can start to garner and gain trust in individuals who look like them. I think it's important, and that's at all levels. That's on the clinical side, that's on the administrative side, and that's on the technology side as well too, so that we are taking into account our lens and view of these issues that are impacting our loved ones and people who like us as well. And then from a technology standpoint, continuing to double down on things like virtual care, wearable devices, AI and machine learning technologies that I think, if used properly, can again start to address some of these health disparities. Because no matter what your socioeconomic background is in the United States and in other countries, in some cases, I've done medical missions to Africa, almost everybody's carrying a smartphone or a cell phone, that device. How can we start to leverage the lowest common denominators of technologies that we have to help provide better education, awareness, and ongoing treatment of those individuals within those communities as well? And then we have to finally hold our politicians and political officials accountable for the policies and legislation that they are passing that has a detrimental impact on access to care, and start to double down on things like, why not figure out a way to eliminate the copay, for individuals who can't afford it, for example, as a means to continue to get quality care? Why can't we offer federally or state-funded transportation to healthcare facilities? Why can't we have mobile care screening facilities that are going out into these communities and meeting people where they are, to Dr. Gore's point as well too? So I think it's a holistic and multifaceted approach to how we start to close that health equity gap.
I absolutely agree with literally everything. As far as the multi-pronged approach, I absolutely agree with everything you said.
Okay. Mr. Kunney, we really hadn't touched specifically on male breast cancer, but could you sort of run through some key differences in male breast cancer and female breast cancer?
Yeah, and Dr. Gore may be more inclined with this. I'm not a physician. I just play one on TV. But I have some statistics I can share being involved with the American Cancer Society. Is that, male breast cancer compared to women or female breast cancer typically happens later in life as well for those individuals, versus in this case, Dr. Gore even talked about a person who was 18, 19 years old, female, that was diagnosed with that. And so the mortality rates for men tend to be a lot lower than females who are dealing with breast cancer, primarily because I think of the estrogen receptors. And again, I'm not an expert on this, so I'm not going to pretend to know that, but we tend to have symptoms that are pretty more pronounced, like a really hard lump in the breast, which is usually hard and painless, which, because of the size of our breast, our chest, we can probably find it and feel it a lot easier in some cases and say, well, what is that? That doesn't make any sense. And diagnose those things a lot sooner as well. So I think in terms of the differences is, one, we see it later in life. Two, I think the symptoms are a little more apparent to us that something is not quite right, and that we're more likely to deal with it sooner in the process. And then the mortality rates for men dealing with breast cancer is, again, a lot lower than women as well. And I'll, again, defer to Dr. Gore to provide more clinical specifics behind that.
Yeah, I agree with that. But I think it's important to also note, as we've mentioned, male breast cancers are 1% of the total breast cancer cases each year. So 2,800 this year, and that continues to go up every single year. And so I think that says a lot about education efforts and just the awareness that's improving overall as it relates to breast cancer care and breast health. I think it's important to note that Black men are affected the same way Black women are, in that they are more likely to be diagnosed with more aggressive disease, more likely to be diagnosed at a later stage. And I've witnessed this personally, especially here in Memphis, not as much in Atlanta, where I also see patients. And so again, I tell patients, if you feel something, say something. Men are not immune to breast cancer. They say, oh, I don't have breasts, so I can't get breast cancer. That's absolutely false. And I've seen it be just as devastating as it is in our Black women. And so regular breast exams, knowing what your body feels like, the same way we tell our women to know what their body feels like. And as soon as you feel something, we don't do routine screening mammography for men because the yield is just very low. But as soon as you do feel something, getting the appropriate help and resources so that the diagnosis can be hashed out. And they won't always feel a mass. I had one male patient present to me, and he actually had intermittent bloody nipple discharge. It would be on and off about 3 or 4 months, maybe once or twice a month. But he's like, this is just getting annoying. What's going on? And sure enough, it ended up being a cancer. And so the same things that we tell women to look out for, we need to make sure our men know that also.
Yeah, and I can speak as a male that unfortunately males like to wait for all illnesses before they come in, and so men have a shorter life expectancy than women because of that. Unfortunately, as a matter of fact, I used to noticed that if I tried to do prostate cancer talks, not that many men would show up, and so I would do breast cancer talks and tell the wives to bring their husbands, and I would throw in some prostate cancer stuff on that.
Right.
So as a clinician, Dr. Gore, treating breast cancer patients, in terms of the emotional impact on the patients and yourself, how do you keep that sort of as something that doesn't overwhelm you?
You know, there are some cases, and sometimes you can still see these patients in the back of your mind. There are some cases that just absolutely tear you apart. I mean, it doesn't happen often, as you mentioned, which is why I love breast cancer, or love treating it rather, because it's so treatable, especially when caught early. And in general, patients do well. Overall survival, 5-year survival across all stages is 92, 93%. And so the patients are going to do well for the most part. But, I do have to hang it up at the end of the day and make a conscious decision to not bring certain things home with me, because it can be extremely overwhelming, especially when I have the 22-year-old who's supposed to graduate from college and now she's over here about to start chemo, And so I lean on my faith. I'm a Christian, and I don't put that on everybody else, but it's something that helps me to stay focused, and I lean with empathy and compassion first. I try to find a way to always build a bridge with all of my patients, regardless of race or religion or gender. And I try to find something to always connect with them, because that's important, and we're on that journey together. And then as far as my patients, I think a lot of them do so well. Number one, when they're confident that they have someone that they can trust taking care of them, and they know that person's going to take good care of them, it brings a certain amount of ease. Not that the journey is going to be easy. I'm always honest with patients, and I let them know what they can expect. There's no second guessing with me. I'm going to shoot straight from the hip. I'm going to tell you what's happening next. And I do make myself accessible at appropriate times so that if they need to reach me, they can reach me. If there are more questions, okay, let's talk about it. And so it's fun being a millennial surgeon, because I feel like I remember the old, and so I have the old school teachers. I remember on our call the other day, you talked about Dr. LaFall, and I didn't go to Howard, but I know a lot about him. And so I carry the old school, but I try to also relate in a new way that's current. And so that's how I do.
So if and I'm gonna throw this out to both of you, in terms of breast cancer in 2023, as far as what advancements or innovations do you think are important? And do you think this has helped patients' quality of life as well as the ability to survive breast cancer?
Chris is going to be better
Yeah.
to talk about some of this, but I got to say, you know, the move from 2D to 3D and just the advancements we're making with our breast imaging and AI has kind of, in a way, always been a part of radiology. They've been on the cutting edge of that and using computer assistance to help with their diagnoses when it comes to looking at the mammograms. Our images, everything has just gotten better. And I do think, even though I do have some old ways, I do think that AI is going to be more of a factor, even when it comes to continuing to plan radiation, continuing to plan, beginning surgical planning, and how do we make even our surgical techniques better so that the patient does better and has improved survivorship.
No, absolutely. And again, I'm not a clinician, but just familiar with some of the advancements that have been made. You know, intravenous chemotherapy, for example, reducing breast cancer in younger women with early breast cancer has been a big leap forward in the treatment. You know, the new drug regimens that are out there that help to reduce some of the, you know, side effects and factors that have been dealt with as a result of chemotherapy and some of the more invasive surgical decisions that have been made. And then targeted, you know, healthcare treatment. The fact that we've been able now to map the genome, we can now provide more specialized treatment to patients based on their DNA, their background. And so things like, what is it, HER2 positive cancer survival rates have now improved over the last decades because of these types of more targeted treatment for patients. And then we're starting to see technologies that are being provided to patients to help with the whole patient experience as well too. Technologies like Outcomes for Me, breast cancer care, OIs, the War on Cancer are all apps that are developed to promote social networking by patients with cancer and for cancer survivors that create the support system for them. And it provides education and awareness and advocacy around how to support these and address and deal with these diseases as well. And then, you know, again, technologies like remote patient monitoring platforms and telemedicine, and to your point, AI and machine learning are all starting to help patients better treat patients where they are, you know, so they're not having to drive, you know, hundreds of miles to get to a specialty clinic to just have a, you know, a regular appointment. They can do a telemedicine consult or virtual care consult in many cases, or they're going to have devices that are monitoring their health that a clinician can respond to if they see any types of anomalies that might be occurring. So, and then again, with AI and machine learning as a part of now research and creating drugs, we're helping to speed up the development of drugs because we can create what they call digital twins. You know, you can mimic an individual's physiology digitally and then provide all sorts of testing and research on that without having to impact an individual negatively with, you know, with drugs and other treatments that might, you know, have an adverse impact on their bodies. So, you know, we're seeing a wealth of different types of technologies that are being applied, both in the research side, the treatment side, and then the ongoing care side that I think will advance the treatment of these types of diseases. Our challenge is, again, bringing that awareness to our community, right? Getting them access to these technologies. They're still not, you know, cheap. They're still, in some cases, very expensive. And still some cases require a certain amount of infrastructure to be in place, like broadband, for example. And so when you get into rural communities, the lack of broadband access makes it difficult to do telemedicine, you know, and other kind of higher end telehealth type technologies. We've got to double down and invest in those things and again, meet people where they are through the use of these technologies.
It'll be interesting to see how telemedicine, telehealth, and AI grow and how it impacts surgery specifically in surgical oncology, because these are traditionally specialties where you do actually have to touch the patient.
Right, right. So you see technology like the Da Vinci knife, for example, right?
But also making it accessible so that these people who do need the care in rural areas who don't have the luxury of going 2 miles up the road, it'll just be very interesting. And also to your point, and I'm sure Dr. Gaskins can speak on it also, just the development of all of the onslaught of drugs over the last 2 to 5 years, that's just completely changing lives. And if a patient stops responding to one, being able to give them another one, which is technically still the same class, the same drug, but seeing how they respond and how they improve, and improving their survivorship in their treatment.
Right. And I think also the aggregation of that data and making that data now available to clinicians like yourself, faster, more accessible, I think also helps you make better decisions about how you treat patients as well, too. So using those tools as resources as you, again, start to treat that patient. In the past, it may have taken doctors 3, 4, 5 years to, get educated, knowledgeable about some of these later advancements, where now you can Google something or search for something and get all sorts of research that's now available to you that you might not have had 10, 15 years ago.
I think gene-targeted therapy is also going to expand on a deeper level. So for example, say somebody's BRCA1, we know that, let's give them neoadjuvant chemo and let's give them PARP inhibitors. We know that this will help improve their response to therapy and improve their survival. But I think that down the pipeline, eventually using somebody's DNA to create drugs that are tailored specifically for them, not for all the people,
right,
in order to improve their outcomes.
Yeah, exactly. Precision medicine.
Okay. At this point, let's see if we have some questions from outside. And I see one in the chat. There's a question: is there a role for preventive measures for breast cancer? And is there a disparity in access to prevention, education, and strategy? I'll throw that to either one of you.
I'll start with Dr. Gore on the.
It's hard because you can't really, lung cancer, we tell patients don't smoke. There's a clear-cut connection. But for breast cancer, there really isn't the strongest connection with anything. So I feel like a lot of the guidance regarding prevention is all the things that we would tell a patient to do anyway to improve their overall health. We know that having a healthy BMI and working out does impact your breast cancer risk. Maintaining a healthy weight. Outside of the ovaries, our fat is the largest reservoir of estrogen. So decreasing your overall body fat, yes, that may help. But the numbers don't lie. It's 1 in 8, regardless of all of these things. Obviously, don't smoke. We do know that there is a connection between binge drinking and development of breast cancer. So minimizing alcohol intake absolutely helps. But honestly, getting screened. Outside of that, I don't think that there's a whole lot you can do, unfortunately, to prevent breast cancer. Again, I think knowing your family history, and especially if there are genetic mutations in your family, knowing if you are also affected, that's the one thing where I know that you can prevent, because you know that you'll be able to actually quantify your risk. But outside of that, I do think that precision medicine will play a role in the future in helping with that. But right now, I do think that the guidance is maintaining overall health to improve your outcomes.
Yeah, I was going to just comment as well. I think to your point, early screening, I think is vital to trying to reduce the likelihood of that cancer causing any sorts of long-term effects on an individual or possibly death. Is one of the best ways to treat it, is to try to get in front of it earlier than later. And then the other thing, you have to be your own advocate too. And to your point, know your body. If you're going to your primary care physician and you're telling them that you've got a lump in your breast or something's not quite right, they're not providing you any sort of additional recommendations in terms of how to diagnose whether or not it might be breast cancer or some other illness. then you need to think about changing
An opinion. Absolutely.
your clinician, or getting a second opinion or third opinion or whatever, because you know your body. And if you know that this is not normal, to my mom's point, okay, get blood in your urine, mom, for years. I mean, you should be asking, hey, ask your sister, you have blood in your urine? If not, then there's something wrong.
Yeah.
You know, you need to go and seek advice from another professional until you get the answers you're seeking. And so that would be my only other advice to individuals, is that do not take, no or nothing's wrong or this is normal for an answer, when you know in your heart and mind that this ain't quite right.
Mm-hmm.
Yeah. That's one of the things I used to remind patients. I used to tell them that if they weren't happy, that they really should seek other opinions, because a doctor is not treating you for free. So anything you're paying for, if you're paying for a service and you're not satisfied, you need to go take your money someplace else.
Exactly.
And so people need to remember that.
Yeah, and I know I used to say to my mom, you wouldn't keep going to a car mechanic if you didn't fix your car. Why do you keep going to the doctor and he's not telling you what's wrong with you?
Right. One quick mention about breast cancer prevention. There was a trial years ago called the Breast Cancer Prevention Trial. And one of the difficulties in that trial was because Howard University was participating in that trial. And what we found that what they were using was something called the Gale model to estimate the risk in these women. And what Howard University found out was that Gale model actually underestimated the risk for Black females for breast cancer. And so I think since then they've tried to adjust the Gale model a little bit, but that's another one of those situations where you creep into these what I call inadvertent disparities that are just inherently there.
Exactly.
Let's see, another question. They said they're curious as to thoughts about the need or potential for personalized diagnostic tests that can test biopsy samples to predict what cancers might be more likely to metastasize.
Dr. Gore?
Dr. Gore, Dr. Gore, you want to take that?
Dr. Gore, take it. So there are some things that we do. So for example, when we get a biopsy report and it's cancer, we know certain things. We know we're going to look at the estrogen and progesterone status. We're going to look and see if it's a HER2 positive or negative. For example, if all of those are negative, then that's triple negative. Well, we know triple negative is more aggressive than some of the other tumor subtypes. No tumor is the same. So I think that within each subtype, there is heterogeneity. To answer your question, there is something else we look at on a lot of tumors, which kind of is a proxy, a really rough proxy for trying to determine how aggressive a tumor may be or how quickly it may be dividing, which is the Ki-67. So the higher that number is, the more likely that we have a more aggressive tumor on our hands. And honestly, I saw this at work like a month ago. I had a patient whose Ki-67 was 80 to 90%, and a tumor that started at 2 centimeters. By the time I got her to surgery, because we just had to get it out, it was over 10 centimeters. And so there are things that we can use to try to determine that. But again, I do think that precision medicine and AI is going to play a greater role as we move into the future with helping to figure out these things a little bit quicker to help guide treatment for patients.
Okay. I'm going to combine sort of the next couple of questions, but it seems to be the idea is, how can we find solutions and deliver to those patients in underserved communities that are on treatment, ways to improve their experience while they're on treatment, including addressing isolation and loneliness that the cancer may cause?
That's a good question. I think I go back to this whole concept of community health workers as well too, and equipping those individuals to be that tip of the spear. Those are the individuals that live in those communities, work in those communities, have relationships with the people within those communities, and equipping them with the necessary knowledge and resources they need to help those patients address the issues that you just outlined as well too. So whether it's isolation, being there and, communicating with them on a regular basis, or whether it's educating them on some of the latest advancements in care, or, finding out how they're feeling and whether or not they do need to go seek treatment. I think, leveraging those individuals can be at the forefront of a strategy that supports individuals at where they are, and especially those who don't trust the traditional healthcare system as well.
I think utilizing our churches and other community organizations more in addition to those community workers, because these are the places where patients go, right? So wherever the patients go, for example, there was all that stuff on ESPN about the barbershops, right? And having these community conversations in barbershops. We can do that at hair salons. We can do that at churches. And I think greater use of some of the smaller organizations that are more grassroots, that do community care. Everybody can't be Susan G. Komen. Everybody cannot be American Cancer Society, but I work with quite a few organizations. One in Atlanta, it's called Painted Pink for Breast Cancer. Their focus is on millennials who are survivors and thrivers, but they do so much in the community, even taking care kits to patients so that they have while they're going through chemo. We need boots on the ground people and organizations, and to give more shine and more resources to these organizations who are actually in the community, who can also be provide for patients and help them out while they are going through treatment. And then, of course, utilizing support groups if those are available. And if they're not available at the hospital or cancer center, then using our churches, using those community workers, using people who can serve as proxies, and also can serve as a bridge between the patient and the doctor when there aren't other people around. Not everybody has a family to help with that.
Okay, we only have about 3 minutes left. So I'm gonna ask each of you to sort of summarize your take on innovation as it impacts breast cancer diagnosis and treatment in today's treatment. Mr. Kunney,
Sure,
you want to go first?
sure. I'll start first. One, I think it's clear that we've seen a tremendous amount of advancement in the treatment of breast cancer just in the past decade or two. So we're seeing survival rates increase, early detection advances taking place, and different types of modalities of treatment are being employed now to deal with individuals based on their unique the uniqueness of the cancer and uniqueness of that individual themselves. So we're moving closer and closer to this idea of precision medicine, and so that's exciting. And then we're starting to see the advancements in technologies that can support those things, as we mentioned before. I won't rehash all of them, but we are leveraging technology as a component to the delivery of care. I do think that, to the conversation we've been having, is that the brown and Black communities typically fall behind in utilizing these different types of modalities of treatment, and we have to continue to have forums like this and become advocates for those communities as well. And then finally, I think we have to continue to double down on developing a pipeline of professionals who look like us as well. So getting into our elementary, middle grade, high schools, and start to instill and plant the seeds around healthcare as a viable career path for them, and not just being, an athlete or a singer or a reality TV star or whatever the genre of the day is. But these are very these can be very well paid, and beneficial and rewarding careers as well too. And so, cultivating a mindset around that, I think, will help to create a more holistic approach to how we continue to close the health equity gaps.
Okay, thank you, Mr. Kunney. And Dr. Gore, give us a quick final statement before we close out.
If you feel something, say something. If you are in leadership, ask the questions of your patients and your staff. What do they need? How do they feel, especially when it relates to issues, health issues, breast cancer issues that impact Black and brown people? And also, don't lift as you climb, lift as you climb. Like everybody has to, think of, I have to think about it. And, we're all capable of having bias. We are all capable of making a wrong decision at any moment. And so thinking about what would I want? What would I like if I were going through this also? I think it really helps to center you and make sure that every step of the way we're making the right decisions for each other and for the people we're taking care of.
All right, thank you. I want to thank both of you very much for participating, Mr. Kunney and Dr. Gore. And thank you, Matter Health, for sponsoring this program.
Thank you for having us.
Thank you.
Thank you all for your participation. And I just want to say thank you to the attendees for joining us. Thank you again to Dr. Gaskins, Chris Kunney, and also Dr. Gore for your participation. And we hope to see you all at Matter events soon. So thank you all, and I hope you have a great rest of your day.